Good afternoon, everyone. Our next topic involves human or provider errors. So we've already seen the things, um, the system errors, those caused by problems in the actual system in which individuals operate. Now we're going to look into human or provider errors, now from the side of healthcare workers, especially physicians. So we're going to look into three topics: the case of the aging physician, number two, disruptive behavior, and lastly, physician burnout. This chapter exposes the challenges faced in the hospital setting due to physician burnout and disruptive physician behavior. Disruptive physician behavior includes bullying. Physicians are the pivot of the healthcare team, and their behavior or lack of up-to-date knowledge, for example in the case of aging, can heavily impact the healthcare system. As you could see, as you would know, doctors play an important role in the hospital. This chapter is going to highlight the consequences for physicians, patients, and the entire hospital team, as well as explore ways to improve patient care and safety. For this first case, this clinical vignette is entitled "Does Age Bring Wisdom?" As I have mentioned before, the hospital setup is highly hierarchical. So from clerks, interns, residents, fellows, and eventually consultants. And even among consultants, there remains some hierarchy. There are junior consultants as well as senior consultants. So it's going to take a lot of time before you proceed upward the hierarchy. So by that time, you're most likely going to be aging. Okay, so this vignette discusses specifically a medical error due to physician incompetence because the doctor failed to keep up with current literature or recertification. Along the way, we're going to discuss the importance of board certification as well as continuing medical education. As we have mentioned before, actually medicine is a lifelong practice, and it involves lifelong learning. The case of a Miss Carroll. Miss Carroll is a 51-year-old female with generalized tonic-clonic seizures for 18 years. So she is a chronic patient of epilepsy. Now, she's stable and she's currently maintained on valproic acid, brand name Depakote. 600 milligrams twice a day with no recent breakthrough seizures. Her physician is Dr. Hawkins. Dr. Hawkins is already a 73-year-old neurologist. So when he had his specialization, it was 40 years ago. And he runs a solo practice. So there's no institutional pressure to keep up to date to recent medical developments. Follow-up lab tests have not been performed for a while ago. So you're going to realize this later on that some chronic patients with chronic conditions, their follow-up is only once a year maybe. That's possible. Now, what are some of the recent developments in Miss Carroll's case? Recently, she has developed these symptoms: anorexia, malaise, nausea, and a reduced appetite. Further, she started having abnormal laboratory findings. She has low platelet count, 95,000 per microliters, also known as thrombocytopenia. Also, she's starting having high liver enzymes, an AST of 196 IU per liter and an ALT of 200 IU per liter. So what's happening here? Actually, this is most likely hepatitis as a side effect of valproic acid. Thrombocytopenia is also a side effect of valproic acid. Her ultrasound findings are consistent with a fatty liver, a condition known as steatosis. So here, the most likely diagnosis is valproate-induced hepatitis. So how could this have been prevented? Actually, if Dr. Hawkins is being up to date with his management, he could learn that there's another newer drug that doesn't have hepatitis side effects. So this is oxcarbazepine. Another option would be the drug levetiracetam. So what should actually be done is the patient should be weaned off valproic acid and started on any of these newer anti-epileptic drugs with minimal liver effects, and follow-up should be conducted every 6 months. Medicine takes a long time to master. So unfortunately, aging physicians, while they have a lifetime of experience, which is very important, effective delivery of high standard care may be impacted, so performance has been observed to decline. Studies have shown that there's an inverse relationship with seniority of age and practice performance. So the older the doctors get, they have worse performance. So what are some of the concerns? Errors observed have been involving history taking, comprehensive data evaluation, and reaching conclusive results. So sometimes when doctors get older, they learn how to do shortcuts. Also, sometimes they rely heavily on first impression. It's because of their wealth of experience, they assume that the current patient in front of them is similar to what they've seen before. So many senior physicians depend on first clinical impressions, and this could lead to a premature closure of the case before conducting thorough history and physical examination. So is this a major problem nowadays? Yes, actually, back in 1975 there were only 50,000 elderly physicians, but by 2013 it rose to 241,641. Of course, you could argue that these are absolute numbers, so they do not represent proportions or percentages. But still, the number is increasing rapidly. For example, in 2015, they found that 25% of the active licensed physicians in the US were elderly, while in 2016, just 1 year after, it rose up to 29%. Okay? So the population of doctors are rapidly aging. And that's where the problem of aging physicians comes in. There have been two theories that have been proposed to explain the declining performance of aging physicians. It's number one, situation cognition theory, and number two, information processing theory. So in situation cognition theory, it highlights how advanced physician age affects thinking in a social setting. So it's an interplay between patient, clinician, and practice. Right? So various factors. But information processing theory distinguishes between two types of intelligence. One is called crystallized intelligence and the other is called fluid intelligence. Crystallized intelligence refers to lifelong experience which remains stable. So it's permanent. While fluid intelligence refers more to analytical problem solving, which is an activity which requires more of a problem solving skill and it requires more energy. And this declines with age. So errors arise because there's a decline in fluid intelligence and a slight overconfidence in crystallized knowledge. So this leads to cognitive shortcuts among aging physicians. So how could we address this concern? So we have four ways here. First is via guidelines and policies. Where would the guidelines and policies come from? It could come from associations. For example, the American Medical Association and the American College of Surgeons have come up with guidelines for assessing senior physicians to see if they are still capable of doing their work. Aside from that, it could also come from institutions. So some hospitals, for example, Stanford and the University of Virginia, have already implemented mandatory assessments. They assess physical and cognitive status of clinicians once they reach a certain age. Next is lifelong learning. Aside from institutions and associations, the impetus to perform self-directed learning should come from the physicians themselves, and they can do that through trusted references. For example, websites like UpToDate, journals, as well as the latest research. So they could keep up with the latest interventions. After all, we don't want a dinosaur treating us, right? Next, continuous education. So there are continuous medical education programs as well as issuance of maintenance of certification or MOCs. These are critical for improving performance, assessing clinical acumen, as well as keeping up to date with current practices. And lastly, work environment. So, the doctor in our case is actually a solo practitioner, right? Sadly, this means that it's more likely that they do not have any support as well as guidance when it comes to continuous medical improvement. So, it has been found that working in healthcare organizations helps with peer support as well as mentorship. Also, it's recommended that within your work environment, there is a way to receive peer and patient feedback. So from the aging physician, let's move on now to disruptive behavior. This clinical vignette is entitled The Zero-Sum Game. This vignette explores the actions of a disruptive healthcare provider. its impact on patient safety, and protocols that should be in place in order to manage these situations. Our case is one of Dr. Richard, a 56-year-old orthopedic surgeon, covering for colleagues during the holidays. So maybe it's against his will, or maybe he's already tired. So this is what happened. While doing his rounds, he receives a page about a new ER patient. So actually, it's really an emergency because it's a fracture coming from a motorcycle accident. But we do not know his reasons, but for whatever reason, he threw his pager at the nurse. Good that it didn't hit anyone. He also abruptly stops his rounds to go to the emergency room, saying he will finish them in the evening. After witnessing this behavior, the nursing staff just says nothing. So both of them are in the wrong here, right? The doctor as well as the nursing staff. Although of course we could understand doctors, especially when they're already tired, and especially when they feel like they don't deserve that kind of work. For example, he's just covering for his colleagues during the holidays. But at the same time, we should not excuse that behavior. And the nursing staff as well should not just let it pass because, as we will see later, disruptive behavior has an impact on patient safety. But first, let's define disruptive behavior in the next slide. How could we define disruptive behavior? So the Joint Commission defines disruptive behavior as any behavior that intimidates others to the point that the quality and safety of patient care is already compromised. So it doesn't necessarily mean that you're being angry, that you're running amok, but it could be categorized into any of these: disruptive conduct, demeaning treatment when you impose or emphasize social hierarchies, passive aggressive behavior, passive disrespect, as well as dismissive treatment. So when you put a fellow healthcare professional, for example, in silent treatment, that still is disruptive behavior. When you perform disobedience, that's also a form of disruptive behavior. So how common is it? Prevalence is estimated at less than 10%. It's not that common. However, it's more commonly seen in certain specialties, such as among surgeons, because surgery is a high-stress profession. One survey has found that disruptive events are most common in medical units, 35%, followed by surgery at 28%, ICUs at 26%, and operating rooms at 23%. So as you can see, in many areas where there are surgeons, you could see disruptive behavior. What are the causes of disruptive behavior? We could divide them into three possible causes. Intrapersonal, meaning within the person themselves. Interpersonal, meaning between individuals. And lastly, organizational, which is somewhat more systemic than any of these two. Okay, so let's look at intrapersonal findings or causes. It could be related to the personality traits because surgeons act like captains of the ship, and they really are captains of the ship. They're responsible for the behavior of other healthcare workers under a particular surgery. Contributory to that are certain personality traits. Sometimes it would get into their heads, so it leads to narcissism. Also, of course, perfectionism. If you cannot tolerate some a underperformance from any other healthcare worker, that's going to trigger your disruptive behavior. Of course, it could also be a manifestation of various psychological states, including depression, fatigue, stress, or burnout. So sometimes they take it out, their stress, on unsuspecting individuals, like nurses. As for interpersonal causes, there may be sometimes a need for control. So sometimes it's just a power trip, so to speak. Sometimes people could be well-meaning, but it's just a form of miscommunication. They did not understand each other. And lastly, it could stem from a drive to have an intimidating behavior. So sometimes in people's quest for some respect, it manifests as intimidation. So the last set of causes for disruptive behavior are already organizational and should be treated as such. So for example, when there are staff shortages, for example in our case, it was a holiday, and so the surgeon had to cover for his colleagues. Then, that's really because of a staff shortage. Aside from that, long working hours. We've already emphasized that medicine has really some of the most abnormal schedules in the different professions. So more than 24 hours, right? And lastly, a high workload. Sometimes if you do not have to rest, then all of that stress is going to accumulate and accumulate until it reaches a certain breaking point. But why do we want to avoid disruptive behavior? Because it's bad, not just for patient care, but also for the entire healthcare system. First, for patient care. The lack of communication may lead to treatment delays. If the healthcare professionals are too busy squabbling with each other, then that would lead the patient to have a delayed treatment. Next, it could also impair clinical decision making. Things that should be logical becomes personal instead. So it also has a negative impact on technical performance. Nurses and junior doctors who are intimidated may also avoid the physician and maybe eventually withhold information just to avoid any confrontations. How about for the healthcare system? For medical students, this may deter them from certain specialties which are notorious to be toxic in terms of work environment. Aside from that, it could also cause stress and burnout among everyone involved, including the residents and the staff. Eventually, it's going to cause huge economic costs in terms of medical errors and staff turnover. People wouldn't like to stay in a toxic workplace, right? And eventually, it's going to cause a legal risk and damages to the institution's reputation. And we've seen some of that in the Philippines, in which patients have resorted to shaming in social media just to complain about the behavior of certain healthcare professionals. So how could we prevent any of these disruptive behaviors? We could start by setting effective standards. So each hospital should have a clear, enforceable code of conduct. So it should be clear that disruptive behavior is not going to be tolerated. It should also provide consequences when work or when professionals engage in these types of behavior. Next would be to try to address the root or the underlying cause why people engage in these kinds of behavior. Because none of us would like to wake up angry at the world, right? So, we could do it by screening for disruptive behavior and offering resources. What are some of the resources that could help people who are always mad? Well, we could give them peer support, mentorship, as well as stress management. And lastly, we could have a way of addressing issues directly, like confidential feedback systems, in such a way that not every way of giving feedback would lead to confrontations or showdowns. So when an issue is reported, how should it be handled? It should be handled with compassion, not putting blame on the person who engaged in disruptive behavior. What it should emphasize is that it should emphasize that the clinician could have resources for stress management as well as anger management. Eventually, if the episodes become recurrent and still continue, well, then it could be documented and administrative sanctions could be imposed accordingly. So let's now proceed to the last clinical vignette. So this is just a short lecture for all of you. Our third and last clinical vignette for this meeting is entitled, Do We Owe Our Patients Our Lives? So we have a saying, you cannot pour from an empty cup. And this is the message that I would like to leave you when it comes to physician burnout. So this vignette discusses a medical error that occurred due to a burnt out physician. So we could not perform our duties well if we are already lacking in motivation. So we're going to discuss how common it is, what are the causes, and what could we do to help prevent it. This case is about Dr. Rhodes. Dr. Rhodes is a 46-year-old primary care physician with a busy practice and family. He increased his workload to Saturdays due to financial pressure, so he needs to support his children and his wife. So he's already reporting exhaustion and poor sleep. In fact, one time, he had a near-miss car accident because he has not been sleeping enough. So one afternoon, he mistakenly prescribes a contraindicated medication to a patient with a history of stroke. Fortunately, the error is caught by his nurse. But as we have learned in this module, we should actually report near-miss events as well. And we should be proactive in addressing the possible causes of this near-miss event. In this case, it is about physician burnout. But first, what is physician burnout and how common is it? It's pretty common because around 46% of physicians in a 2015 Medscape survey reported that they have at least one symptom of burnout. And what are these three symptoms of burnout? Well, there's a low sense of accomplishment. So doctors would commonly complain that they have a lack of efficiency. They are unable to perform their activities of daily living. They are unable to perform their functions at work. So this causes a discouragement in one's own potential. They no longer believe in themselves. Next is emotional exhaustion. Um, so both physical and mental fatigue could contribute to this feeling. Eventually, this could lead to depression or major depressive disorder, and eventually possible suicidality. And lastly, there's the symptom of depersonalization. This is what we call an impersonal attitude towards patients. So they burnout patients, burnout physicians only act as if they are robots. They are no longer feeling empathy towards the concerns and emotions of patients. Burnout is more common on certain specialties. For example, it has been found that it is highest in emergency medicine because it is a high stress environment, followed by primary care because you meet all sorts of patients, right? And obviously, there's also general surgery there because they have a lot of responsibilities. Um, so, what are the specialties that aren't there? Well, we don't see in this graph pathology or radiology. These are um, these are diagnostic specialties which do not really have a patient-facing role as much as the other clinical specialties. So maybe that helps in preserving the sanity of these doctors. So what are the contributors to burnout? There are some work-related factors and personal factors. For the work-related factors, they are relatively obvious. Long working hours, of course. At the end of your duty, you're going to have less emotional quotient to draw from, right? Next would be an increased work intensity as well as an increase in night calls because they interfere with your rest period. Um, your colleagues could also be a big part of it. If you lack colleague support, then you just internalize all the stress. And lastly, excessive documentation. So, this has been reported in the United States that due to insurance pressures, they spend most of their time in front of the computer documenting instead of doing the actual work of a doctor, which is history and physical examination, right? So because of that, some physicians feel that they are just computerized physicians. No? Instead of being doctors, having a rewarding career as a doctor, they are just record keeping. So now let's look at the personal factors. Those who are younger have a higher risk. So maybe due to multiple reasons, it's possible that it could be that they are receiving the brunt of the work responsibilities. Or maybe they are just less confident in their status as doctors. Also, women are at higher risk. Family responsibilities, when it coincides with work responsibilities, especially when they clash, could also be a contributor to burnout. And lastly, of course, the financial status. If your salary is highly delayed, then of course you're going to feel some stress or you're going to feel that your work is not worth the effort. Let's look now next on the consequences of burnout. What are the consequences of burnout? Burnout imperils the physician because it increases your risk for suicide by around 40 to 130%. Of course, it also compromises patient safety because it creates medical errors. It also endangers the doctor um, because it could place them at risk of having malpractice lawsuits filed against them. For the organization itself, for the hospital for example, it also creates a financial burden because it reduces productivity and because it causes a high rate of job quitting among physicians, then it would require a higher replacement cost. How do we assess burnout? For that, we have the gold standard, which is Maslach Burnout Inventory or MBI. So, again, repeating the three domains: emotional exhaustion, depersonalization, and personal accomplishment. If you have a high score in emotional exhaustion or depersonalization, specifically more than 27 for emotional exhaustion and more than 10 for depersonalization, That's indicative of burnout. Also, if you have a low score in personal accomplishment, less than 33, that's also indicative of burnout. So what could you do? Well, there are things you could do as an individual and things that the institution could do for you. First, positive thinking is actually good. Of course, that's obvious. but and also good coping strategies. You need to find what works for you. Resilience, of course, is a personal characteristic. And we could learn them, right? Also, we could learn some stress management skills. Um, Physical activity and exercise could also help. And lastly, your family and your friends could help you. From the organization, it could help by being well organized. Sometimes, bad work schedules promote burnout. Of course, you could also do regular assessments, maybe using the Maslach burnout inventory. Should promote good relationships in the workplace by promoting teamwork, team building activities, as well as camaraderie. And lastly, you could provide resources and support systems such as education and counseling. In conclusion, this is for the entire lecture. This is the last slide. Provider error is a complex issue stemming from multifaceted human factors. So we need to address aging physician competency, disruptive behavior, and physician burnout. Because although these issues are individual, they have a critical effect on patient safety as well as in our institutions. So it requires a combination of both individual accountability and systemic change. Both the institution and the employees must meet halfway in order to create a safe and healthy healthcare environment for everyone. And that's just it for our lecture. Thank you very much for listening, everyone. If you have any questions, just message me. Thank you.